Hi, I'm Jenna and this is Ida. This video is going to be about how to place an epidural for labor and cesarean section. First step is identifying if the patient is a good candidate for an epidural. We need to make sure they have given their consent, they don't have severe hypovolemia, aortic or mitral stenosis, any uncorrected coagulopathy, or infection of the lower back. The next step is to explain to the patient what the steps are and what is going to be required of them. When they are located where you'll be placing the epidural, have them move as far back as they can so when you're behind them, you don't have to lean over to reach their back. Positioning is also very important. You want them to stick their back out and hunch their shoulders over. This is important so the spaces that you're aiming for are as big as possible. So when you're looking at the spine, if somebody is sitting with really good posture, their spaces are very compressed and you cannot see the epidural space because the target is very small. But if you have them push out their lower back and hunch over, then their spaces open up and the target is much bigger. Sometimes patients have to be shown this position rather than just telling them to hunch over and push their back out. Handing the patient a pillow to hold and lean over can help them position better too. Next, you should identify where the epidural will be placed, which is at the L3-4 interspace. When the patient is positioned, it's important to identify where your epidural will be placed. You can use a variety of landmarks to identify this. When you're looking at the spine, you first want to locate the L4 spinous process. To do this, the most important anatomical landmark to use is the top of the iliac crests. Sometimes it can be hard to feel, but pushing on the back and not the sides of the patient can make it easier. Putting your hands on either side of the spinous process, you can use your thumbs to meet in the center of the back, over the spine, and at the same time feel for the L4 spinous process. If it's hard to feel, you can palpate either side of the spine, running your fingers up and down to feel for the ridges and depressions. Depending on the patient's anatomy, the top of the iliac crest might fall between the L3 and L4 space or between the L4 and L5 space. But the main spinous process of L4 should be the closest to the top of the iliac crest. Also, when you're looking at the spine, other important landmarks are the bottom of the ribs, which are at T12 vertebrae. The bottom of the scapula should be at T7 level. And when you're doing epidurals for vaginal labor and delivery, the epidural level should be at around T10. This is the dermatome level, that is the sensory stimulus for the contractions and cervical dilation will reach. If a cesarean section is needed, then the epidural level should reach T4. This is because nerves that are supplying abdominal and pelvic organs travel in the sympathetic trunk, which includes levels T5 to L1. Cesarean sections are also more stimulating and involve more stretching and pulling on the abdominal tissues. So once again, once you have identified L4, the ideal location to place the epidural catheter is in the L3-4 interspace. Mark this space using your nail or something else to put an indentation into the skin. This way, when the area is cleaned, it is easy to identify exactly where the skin puncture will be. Since L1, L2 is where the spinal cord stops in 90% of people, we will want to be well below this level to prevent damage to the spinal cord. Once the spot has been identified and I know where I'm going to puncture the skin, I mark it and then start setting up my epidural tray. First, I open up the sterile cover in a way that keeps the inside sterile, and then I'm going to put on my sterile gloves. My sterile gloves. First, I want to clean the site, so I'm going to open up my betadine and empty it into the tray. To clean my site, I'm going to start at the injection site and scrub it well and work my way out in concentric circles, throwing away the used swab and grabbing the next. The betadine needs to be completely dry to clean the skin effectively, and this takes about 2 to 3 minutes. So at the end, while this is drying, then I can set up the rest of my tray. To set up the tray, first make sure everything is open, out of its packaging, and easy to grab. Open up the ampules that contain the medications. Here, I have the 1% lidocaine to numb the skin and a label for it. Next, I have the 1.5% lidocaine with 5 mics per mil of epinephrine for my test dose. Oops, don't throw the syringe off the sterile field. And then saline for the loss of resistance technique. Finally, don't forget to label the epidural catheter to make sure it is never accidentally used as an IV. After it's been 2 to 3 minutes after the skin has been cleaned with betadine, then you can apply the sterile drape to the skin. You want to make sure the drape stays sterile, so make sure it doesn't hit anything as it's being opened. Line up the desired injection site in the middle of the circle and stick the drape to the patient's back. Next, you want to inject the 1% lidocaine to numb the skin. While injecting lidocaine, use the needle to try to find the path and angle needed to get through the spinous processes. If you feel bone pretty shallow to the skin with this needle, try a different angle. Make a mental note of this angle because this is how you will want to introduce the epidural needle. The average distance from the skin to the epidural space is 4 to 6 centimeters. So each of these markings on the epidural needle is 1 centimeter. So here we have 1, 2, 3, 4, 5, 6, 7, 8, 9. And then this little window here is where you can see the catheter when it's inserted and is going to be the 10 centimeter mark. So the average distance is 4, 5, 6 centimeters to the epidural space, so the needle should be inserted until about here. Insert your epidural needle until it's pretty snug in the ligaments and you know it's not going to fall out, and then you can take the stylet out and attach the loss of resistance syringe. There are a couple techniques you can use to find the epidural space. First, you can insert the needle a couple millimeters at a time and test the syringe to see if there's resistance. This is my preferred method, or you can try to hold continuous pressure on the syringe while slowly inserting the needle until you achieve loss of resistance. Once that resistance is gone, the end of the epidural needle is in the epidural space. Now you want to remove the syringe, make sure there is no cerebrospinal fluid coming out, and then you can start to thread the catheter. You want to note how deep the epidural needle is in the skin to the epidural space. So I have 1, 2, 3, 4, 5 centimeters sticking out, so I know there's 5 centimeters in the skin. No matter what, I want to insert the catheter until there's 3 hash marks seen in the window of the needle. That way I know there's 5 centimeters sticking out the end of the catheter in the epidural space and 10 centimeters inside the needle. If the catheter doesn't thread easily, the needle may have come out a little, so the catheter cannot pass through the skin right at the end of the needle. If you advance the needle just a millimeter or so, it will re-enter the epidural space and the catheter can be threaded easily. If this doesn't happen, then the needle should be removed and the process started over. Now you can see the 3 hash marks in the window here. So you know you're at 15 centimeters. So there's 5 centimeters sticking out the end of the epidural needle. Once you reach this point, you can insert an extra centimeter and then you're going to remove the epidural needle as you push the catheter in to prevent a portion of the catheter coming out with the needle. You want to be very careful not to pull the catheter because you cannot just push it back in. Once the needle is out of the skin, you want to be careful and wind the catheter up on your fingers so the catheter doesn't hit someplace that is not sterile. Since it was 5 centimeters from the skin to the epidural space, the catheter should measure 10 centimeters at the skin, which is indicated by the 2 hash mark sign. That way I know there's 5 centimeters in the space and 5 centimeters in the skin. Right now I'm at 13, so I'm going to have to pull back a couple centimeters until I can see the 10 centimeter marking. Now I want to test to make sure that the catheter isn't subdural, intrathecal, or intravascular. So I'm going to attach this catheter to syringe adapter to the end of the catheter. That way I can inject the 1.5% lidocaine with 5 mics per mil of epinephrine test dose. The first thing you want to do is aspirate. Pull back on the syringe and make sure you don't see any barbitage, which is the swirling of cerebrospinal fluid or blood. The timing of the test dose is important. It must be between contractions in the laboring patient. This is because if an intravascular injection will cause an increase in heart rate, but that might be masked by the pain of a contraction. As long as the timing is good and no blood or CSF is seen, you can go ahead and push your 3 mils of lidocaine. After pushing your test dose, you need to wait at least 5 minutes to make sure there are no signs of an intravascular injection. These signs are circle oral numbness, ringing in the ears, and an increase in heart rate. These signs can be seen as early as 30 seconds and can last up to 5 minutes. So also allow enough time to make sure this hasn't occurred. An intrathecal injection would cause numbness in the legs within 3 minutes. As long as there's no signs of an intravascular injection or intrathecal injection, you can bolus the epidural. To bolus the epidural, typically 0.0625% or 0.125% bupivacaine is used for labor, and 0.5% bupivacaine is used for cesarean section. You want to bolus very carefully, so even though you just tested the catheter, you still want to pull back and make sure there is no blood or CSF. As long as you don't see either of those, you can go ahead and bolus 5 mils. Since the catheter is long and small, there is significant resistance felt. That is normal. Once 5 mils are in, then another aspiration attempt should be made because the catheter may have migrated after the bolus. Then you can bolus another 5 milliliters. You can always aspirate more often, like every 3 mils, but you have to do it at least every 5 milliliters at minimum for safety. The total bolus dose is often dependent on the height, age, and position of the patient. So after 10 milliliters have been injected, the injection should be paused for 3 minutes to assess the height of the block. If it hasn't reached the desired level, then an additional 5 mils can be bolused at a time until the desired block is reached. While you're waiting for the block to set, the catheter can be secured. You want to put your dressing on and then remove the drape. You want to be careful not to take the catheter out as you're removing the drape. Secure the catheter very well with tape to prevent it from accidentally getting pulled out by the patient when moving. Thank you for watching our video on how to place an epidural. Please review the PowerPoints, epidural overview, complications of epidural anesthesia, and how to convert to a cesarean section. Thank you.